This is Dr. Murphy of the Department of Anesthesia at the University of Kentucky, and this is podcast part 2 on the management of perioperative pacemakers, AICDs, and the principles of defibrillation. The topics on today's videocast will be concentrated on AICDs and defibrillation. This is a very busy slide with 5 pacemaker codes and 4 generic defibrillator codes. So therefore I'm going to divide that slide into 2. This slide has 5 CIED codes for pacemakers. That is chamber paced, chamber sensed, the response to sensing, the programmability, either no programmability or rate modulation, and finally whether or not there is multi-site pacing. A biventricular pacemaker defibrillator with shock and antitachycardic function would be labeled DDDRV for pacemaker code, and would be labeled VVE for the defibrillator. Therefore, that kind of device would be labeled or designated VVE-DDDRV. Pretty confusing. Now here's an algorithm, and on this algorithm you see reference to a CIED physician in the preoperative management, and this refers back to the recommendation that there be an institutional solution for these devices. Now, following this algorithm, if EMI is unlikely, then you proceed directly to postoperative management. This slide does have some practical advice regarding the magnet, and that is that the switch on the CIED should be active, and that the patient should be supine, and that the magnet should be observable, and that the magnet should not be in the surgical field. Now, for cardiac surgery, the magnet can be in the surgical field if placed in a sterile bag and the surgeon is willing to take the responsibility for its management. One reason why some cardiac surgeons may decline reprogramming in the perioperative period is that they do not have control over the pacemaker, and that it could be placed in an asynchronous mode, and that an R on T beat might occur and fibrillation might ensue. It is possible, but not very common in my experience in the cardiac OR. Regarding postoperative management, if there were no reprogramming and there were no EMI and no other considerations, you're done. But if not, you have more work to do. One interesting item on this slide is the mention of Infra umbilical surgery, which allows for a delay in post-op programming or check on the device for up to 30 days. Now moving to transcutaneous pacing. This is a cut and paste summary from open anesthesia, and the bottom line is that with transcutaneous pacing you have to be certain that there is a pulse. As it says on the slide, finally, do not be fooled by the monitor into believing that the appearance of QRS complexes means that the patient's heart has been captured and is delivering a sustainable blood pressure. You need to have some way to tell that the heart is being paced and generating a blood pressure. Have a pulse oximeter or arterial line waveform for confirmation of the monitor's electrical activity.
When it comes to transcutaneous pacing, it's up to you to know how to use the equipment that the hospital has provided for you. That may require you to refer to YouTube videos or to the instructions for use, or perhaps have the vendor come into hospital and show you how to use it properly.
Now, personally, I've never paced a patient transcutaneously, but the next few slides do summarize how to do it. As it says, the placement of the pad may vary by manufacturer, but is generally antero-posterior, and it is recommended that you start with a low current and increase by increments of 10 until capture is noticed. The target rate, of course, being a normal heart rate of 60 to 80 beats per minute. And as it says in the slide, this transcutaneous pacing can be quite uncomfortable and may require sedation and or analgesia. The external pacing should be evaluated by palpating a pulse and other physical examination criteria. It is safe to touch the patient during patient pacing. There are pitfalls with transcutaneous pacing, and as it says on the slide, skeletal muscle contraction can occur at low amperages, low currents, and it does not necessarily mean that there has been electrical or mechanical capture. Current should be increased as much as necessary for electrical capture. There is a short 3-minute video which you can watch by copying the browser link shown at the bottom of the slide, and if you want to see a demonstration or a simulation of transcutaneous pacing, that is a link that you can try. Now, moving to transvenous pacing. This slide shows the equipment that's necessary for inserting a transvenous pacemaker. And in addition, there is...
If you have a percutaneous entry sheath in the internal jugular vein, it is generally not very difficult to advance a pacing catheter into the right ventricle and to capture the right ventricle.
This is a keyword question, and kind of summarizes these two podcasts. Now, defibrillators.
The remainder of this video cast will be concentrated on the principles of defibrillation.
I suggest that you read this chapter from Anesthesia Equipment and Principles and Applications, 2nd edition. And as you notice, it's authored by Dr. Ross Zoll, and therefore written by someone who's had a fair bit of experience with defibrillators, since the Zoll brand of defibrillator is what we currently have at UK. So, one slide on the history of defibrillators. And these are the key points about defibrillators and defibrillation. Defibrillation stops the dysrhythmia so that normal cardiac rhythm can resume. A defibrillator is a complex electronic device using a capacitor to store electrical energy and to release it in a prescribed way. Both alternating current and direct current electricity are involved. The shock that is delivered is direct current. Rectilinear biphasic waveforms reduce the peak current administered while delivering an effective dose, and this is one of the selling points of the Zoll defibrillator that we have. Resistance decreases after a dose of defibrillation energy or a shock, and therefore repeating the same dose may be as effective as increasing the dose of current.
We'll discuss the technology of defibrillators.
What is fibrillation? How does defibrillation work? And as we will cover, is defibrillation without complication? So under technology, as I mentioned a few minutes ago, a defibrillator is a capacitor, and this is a schema of a capacitor. Can't say that this will be shown to you on a quiz, but this is what a capacitor looks like schematically. What is fibrillation? Fibrillation is a random and chaotic re-entrant arrhythmia. The myocardium is in a unique, unreproducible electrophysiological state, which is part activated, part refractory, part relative refractory, and part perhaps resting. That is a definition of fibrillation. How does defibrillation work? The basic principle of defibrillation is to interrupt a random and chaotic electrical activity in the heart by using a large stimulus that excites a large and sufficient fraction of the muscle mass at once. There are three main conditions which influence the success of defibrillation, and they are the duration of EF, the severity of hypoxemia, and the presence of acidosis. Of the controllable factors that influence defibrillation, these appear to be impedance and current flow. Current flow in the myocardium depends almost entirely on delivered current and geometric factors. Unfortunately, most defibrillators do not indicate the delivered dose of current. The actual dose of electricity which is delivered is actually quite variable. Extracted from that chapter is the statement that the new rectilinear biphasic waveform largely corrects for this variation in current dose, as well as provides a more effective shape. This is the shape. Now, the definition of rectilinear is straight lines. Now, if you believe the Zoll explanation for improved efficacy of the proprietary Zoll rectilinear biphasic waveform, you will therefore accept the concept that the dose of current, rather than the peak current, is the most influential variable. Also, there appears to be an optimum duration for the shock, and this appears to be in the order of 6 milliseconds. So to reiterate, a prior shock reduces impedance, so a second shock may be more effective. And since patient impedance varies by more than twofold patients, such as factors such as patient weight and the interface and paddle pressure and the use of disposable pads have little effect on the success of defibrillation as compared to patient impedance itself. This slide and its two figures from that chapter show the old underdamped defibrillator waveform on the left and the new truncated exponential waveform on the right. Now, this statement here refers to the presence of external, or not external. This refers to the attachment of patch electrodes to the epicardium of the heart, as it used to be performed before transvenous AICDs were invented. So if there is an epicardial patch electrode, it may interfere with the delivery of electrical energy for defibrillation. It may not be very relevant these days, although you may run across a rare patient who has had direct myocardial epicardial patch electrodes attached to his heart for defibrillation. Now, just as a myocardial or epicardial patch electrode interferes with a defibrillation, so does air, so does a pneumothorax. There was a time when robotic harvesting of the internal mammary artery was in vogue, and this case report, authored by Drs. Hatton and Schell, reported the failure of defibrillation when there was an iatrogenic pneumothorax with one lung ventilation. Like intravenous medicines, electrical current has a dose-response curve, and these graphs show the relationship between peak current and clinical success for VF and VT. So, no pun intended, a burning question: is defibrillation without complications? It is stated that too much current can produce damage to the myocardium that may or may not be thermal in nature. Damage to the cell membrane and contractile structure may lead to depressed function, necrosis, persistent arrest, or fibrillation. Overdose of current may therefore result in failure to defibrillate. So there appears to be a therapeutic window for effective defibrillation. Pediatric defibrillation does have guidelines, and it is recommended that the first attempt use a dose of 2 joules per kilogram, and that subsequent attempts for defibrillation in children use 4 joules per kilogram. Using a little bit of math, you can see that above 50 kilos, adult doses would most likely be the dose to follow.
This Zoll advertisement is trying to explain to you how the modern CFL bulb, which uses less energy, is as good or better than the old incandescent bulb, and by comparison the modern high current low energy biphasic defibrillation by Zoll is better than the old-fashioned way. This concludes this video cast. I hope that the illustrations and information have been useful to you and will be beneficial in your self-study of these topics. Thank you very much.